We'll go ahead and get started. So I want to welcome you to Persyst Grand Rounds, an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. My name is Marie Terrell, and I am the Director of Product Management with Persyst, here to introduce our speaker and topic for today's Persyst Grand Rounds. Next slide. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their experience and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. You can visit www.persyst.com/grandrounds to keep up to date with the schedule. Next slide. So here is our disclaimer page. The opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst. Persyst is not providing any form of compensation. And last slide. So there will be time for questions after the talk, and you can write your questions in the Q&A area. You'll see a button at the bottom of your screen. We are also recording the webinar today, and a copy of the recording will be made available to all participants afterwards. And now I would like to introduce you to Dr. Juan Pablo Appendino, a pediatric neurologist epileptologist at the Alberta Children's Hospital in Calgary, Alberta, Canada. He is a clinical associate professor in the Department of Pediatrics at the Cumming School of Medicine at the University of Calgary. Dr. Appendino is the current president of the Canadian Society of Clinical Neurophysiologists. He is also the director of the Neurometabolic Therapy Service. He has participated in several committees in the Canadian League Against Epilepsy, including the Canadian League Against Epilepsy, the American Epilepsy Society, and the Ibero-American Academy of Pediatric Neurology. His main clinical research interest includes EEG trends, the use of them in neurocritical monitoring, drug-resistant epilepsy, epilepsy surgery, ketogenic diet, and autism. He is an international reviewer for several journals and has received awards in teaching, research, and humanitarian practice. He has co-authored several papers, written book chapters, and conducted clinical research guiding international students, residents, and fellows in their quest for medical excellence. And he is a surviving father of 2 teenagers. So without further ado, I would like to introduce to you Dr. Appendino.
Thank you, Marie, for such a great introduction. And yep, 2 teenagers. I'm not sure if I'm surviving, but anyway, I'm doing my best. So today we're gonna try to talk a little bit about advanced EEG monitoring the neonatal intensive care unit, which is one of my interests. And I hope I can share with you my learnings along the way and inspire you to continue enriching the field. I have nothing really to disclose. There is no financial relationship with Persyst, and I'm gonna show though many screenshots because that's the system we have in our hospital. However, there are many in the market, including Ensevis, Bitium, Synopsys, BrainQuick, etc. So we have at least 3 objectives today. I'm not sure what's going on with the mouse, but seems to be that it likes to move the slides around. We're gonna build skills to understand the current solution and limitation of the EEG monitoring the neonatal intensive care. We will identify and implement the best available tools for neonatal EEG monitoring and interpretation, and we will examine and assess the impact of background and seizure monitoring in some trends. Now, I'm gonna combine all these objectives all along the talk. So stay with us. You will have all those objectives achieved by the end of the presentation. Some key concepts that when we are reviewing our EEGs in the neonatal intensive care unit is a little bit important to consider. The maturation of the brain is very dynamic in the neonatal period from 25 weeks until 44. That is the whole perinatal period. The EEG changes quite a bit. And the reason is the brain also changes quite a bit from 25 weeks gestation, from a very almost looking like a lissencephalic brain without sulcation to the newborn. There are many stages that the EEG and the findings change. And the EEG is formed by the neurons that are in the cortex, but those interact with the basal ganglia that is, I'm so sorry, I'm not sure what's going on with this mouse, but I'm gonna try to not make it change that quick. So as I was saying, the EEG have captured the electrical activity in the interstitial space generated by the pyramidal cells in the cortex, but those pyramidal cells react to, I'm gonna put a laser, so maybe easier for you to see, but the thalamus interact with the pyramidal cells in the cortex, and that is also the generation of different waveform. And this interaction back and forth is what it forms the different frequencies in our brain. Here we see an EEG, which is completely normal for a 20 weeks old corrected gestational age, with burst and suppression. Would look like if this was a term or an older child, but this is a trachea discontinue, which is very normal in a newborn. Well, 40 weeks, we have a continuous symmetric background activity that this communication back and forth, as I was mentioning, is more sustained. But all these interaction form the combination of different frequencies and different discussions between the cortex and the thalamus, between the cortex itself, that form the different frequencies of oscillation. And if we are able to tease out the overall formation of this single original signal recorded by the electrode in the cortex, in the skull, we can see that there is a combination of different frequencies to form this trend, this wave. We have delta, theta, alpha, beta, and different frequencies of beta. And when we are able to tease out all this information, we can see the percentage of each of the waveforms, and we can then transform this information into the trends that you will soon see more in the next slides. But essentially what we do with the EEG and the trends is we analyze two big components, is the background activity and if there are seizures or not. And in the background activity, we try to see if it is continuous, discontinuous, or suppressed, if it is symmetric or asymmetric, if it is synchronous or asynchronous, and if there is a sleep and awake cycle, which is a very important and healthy behavior of the brain in newborns. And then seizures, if there are focal or generalized, which actually there is no such a seizure type in newborns called generalized, but rather sequential, and you will soon see some examples. And if they are electrical or electroclinical. So, but why do we use, or what is the intention of these trends, is to help in the prognostication, because as we all know, from Dr. Payne's work from almost 8 years ago, that the more seizures you have, the worse your outcome is going to be, particularly if it is more than 20% of the time, which means um, um, 12 minutes or more per hour. That will lead to a worse prognosis. And because it's also guiding us in help our patients with um, progression of anti-seizure medications, or if we see changes in the background, it may prompt us to go for MRI or ultrasound or LP or others. So um, I'm going to make it a little more interactive, and we will go over this. So what happened here is we have a case in which this is the typical screen that you will find in your NICUs when you go and see the EEGs, if you're lucky and you have the full EEG montage for a neonate, which is a reduced 1020 montage for neonates with 11 electrodes rather than the typical 19. And then in the bottom, you will have, or outside, whatever, you will have the Amplitude Integrated EEG, in which the your colleagues in NICU will look at this section of the screen, and you from your office or your reading station or at the bedside, you will focus on this screen. This screen, the problem is you have 24 seconds, and in this one you have 4 hours of recording, which is quite a bulk of information about that brain functioning and healthiness. Now, we're going to go over this case. It's a baby born at 37 and 1 week, so term. Decreased fetal movements prior to birth, had meconium, was thick, then born to in poor condition, IPV of 13 minutes, hypotonic at birth, tone gradually improved, started passive cooling at about 1 hour of life. And then the active cooling started at 4 hours of life, and the study started at 9 hours of life. So now, how about if I tell you that in these trays, there is a seizure? And here is when we start getting a little bit um, um, into the discussion about the Amplitude Integrated EEG and the EEG, and how much do we know and how much can we help our colleagues in ICU. So Marie, can you please put the poll number 1?
Yes. Poll number 1. Okay, so because we had used this as a, oh, here we go, relaunch poll.
Yeah.
Yes, okay. So are you able to see the poll?
Yes, I am, and I'm
Great.
sure our participants also.
Yes.
And you probably are going to be able to see the answers.
They are coming in.
Okay, so
Yes.
we are
Okay.
going to give 10 more seconds. It's a very simple, easy, it should be okay. I don't know how many answers you have, but we have 187 participants at the moment, so hopefully we'll have enough. All right, why don't you show the results?
Okay, poll ending in 3, 2. Okay, and here are the results.
All right, so we have the vast majority thought there was a seizure at C, which is very typical of an amplitude integrated EEG, the abrupt onset or increase of the lower margin of the trace, but there were also some here. And so I'm gonna I don't know if everybody can see the results, but I can say I think everybody can see. So we're gonna move along, and we will discover which one it really was actually. So we have number A, that you all answer number B, you all answer number C, that was the winner. Actually, it was not a seizure, but rather C. Sorry, D. So how how on earth did we miss that? Um, so, however, if we would have been able to use other trends that are not really conventionally used in the NICU, but I'm loving it because it gives us a lot of information, we would have been able to see easily some of those seizures. And you can see how clearly the seizures were seen in some of the trends, but not all of them. Um, so, um, and why? So, okay, I'm sorry, I'm having my own camera in middle of the screen. So why weren't we able to see it very clearly? So you can see the injury, where the injury happened in this baby with HIE, but more metabolically active, this occipital um, um, cortex that actually are the ones that cause the seizures. So we were even more able to see further information. For instance, reducing the screen at 16 hours, we can see the whole behavior of almost a full day of this brain. And we can see that there were several seizures, but then the child, once we recognized those seizures, we were able to load the child with midazolam. So he was loaded with levetiracetam, then midazolam infusion, and seizures improve. And you can see also the background activity that also became not nicely formed. There were no awake and sleep cycling, and it became a bit discontinuous. So you will see over time that those details waveform. So why did we miss the seizures on the EEG trend? Because the seizures, usually the EEG trends, are set up to see the central areas, central temporal, Rolandic, around Rolandic area. But in our case, the seizures were very occipital. In this particular case, occipital, right occipital leading, and then followed by the left occipital. So it's known for many years that thanks to Rene Schelas, that we can miss 1 out of 4 seizures, if not out 1 out of 3, depending if they are repetitive or single seizures, in patients where in the AEG, when we only set up in the central temporal head regions, which is the vast majority of our NICUs, how they set up their amplitude integrated EEG. And if you have either in the 2 poles, either frontal seizures or occipital seizures, you will miss 1 out of 2, or even less than 1 out of 2, so, or more, better said. 58% of the seizures can be missed, and 54% of the seizures, if it is frontal, can be missed if we only read in this region. So it's a very, very important concept. We need to utilize and put the electrodes, our eyes, where the problem is. For instance, here we have a single amplitude integrated EEG that compares the left and right central areas, and obviously they miss it because the seizures were very occipital. In this case, for instance, if we put the electrodes here as an example, that is very incorrect because we're going to be missing the seizures. Now, if we put it more posterior than the central head region, we will very likely see them because our eyes are in the regions where the seizures are coming. Therefore, a concept, traditional AEG, excuse me, alone may not be enough. other trends could be helpful. Adapting location of the EEG electrodes according to each patient seizure may also help. So very important concepts for us to use the trends. And what are the actual trends then? Well, they are useful complementary tool for the regular EEG. You help us in the interpretation. How is it? Well, as I mentioned before, we tease out all the component of the waveforms, the alpha, the delta, the theta, and we transform that raw EEG digital data into a more compressed time scale channels that displays several hours of recording on a single graph page and focusing on different characteristics of the whole brain function. For instance, symmetry or frequency or rhythmicity and so on and so forth. The interpreter then can easily recognize the slow and evolving trends of a background activity, quantify the number of seizures, identify certain seizures pattern, identify sleep and awake cycling, and with that, it guides the management of the seizure. What types of spectral array are there? How many trends do we have? Well, all depends on the software you're using. I'm going to go over some of those that we use here, but we don't always use the same, and we try to see which one are more helpful for each patient. But in general, as a concept, we can say that the overall arrangement of the screen is time and other. And the other is usually frequency or probability from 0 to 100. For instance, here we're seeing a clear left hemispheric seizure. This is a focal seizure. You can see some rhythmicity, some asymmetry pointing towards the left hemisphere. And in some trends, for instance, the fast Fourier and spectrogram will show not only the frequencies and the time, but also color coded the power of this activity. The more powerful, the more bright, more hot that color is. And then the percentage will be, for instance, in suppression ratio that you will soon see. And how do we get into this power? Having three properties, color-coded, frequency, and time, we kind of use a 3D view of the actual seizures. And it's a seizure print. Most of the seizures in each patient will have its own manifestation. For instance, you can see this is a different patient in which the patient had over the right hemisphere a frontal lobe seizure that started with higher frequencies and then gradually went down. While in this patient on the left hemisphere had more a monotonous kind of onset in the range of about 10 to 12 hertz seizure. And with the power, we analyze the lower the frequency and the higher the amplitude is, the more power that seizure will have. Anyway, so we're going to start with the one that everybody knows and or is aware of. And we're going to kind of tease out a little bit more the amplitude integrated EEG, and then we will go over the other trends. But so the amplitude integrated EEG is it's a compressed filtering out frequencies lower than 2 hertz and higher than 15 hertz because the brain in newborns do not have faster frequencies. There is too immature, cannot, although there is research talking about high frequency oscillation in newborns. So it's kind of, we are rethinking about these higher and slower frequencies. Nonetheless, we know that slower than 2 hertz is very unlikely to have seizures. However, as you can see here, there are very slow seizures of 1 hertz that also can be missed. So we need to be aware what are the settings that we set up in our trends as well. And that's why some seizures may some AEG may be blind to some seizures. And here you can see a very clear difference between active, cycling, awake and sleep brain having intermittent seizures, while this child, you can see a quite suppressed brain activity, as you can see in the Amplitude Integrated EEG. So display the data in a compressed manner. You can see these are 4 hours of recording. These are 10, 15, 20 seconds of recording. And it has a direct linear relationship between 0 and 10 microvolts amplitude, but then from 10 to 100 is a logarithmic display. Therefore, to make it very narrow, the amplitude of the waveforms. You can use it in a single channel. You can use it among many other channels. Here, as you can see, the Amplitude Integrated EEG in this particular arrangement is not blind to the seizure, even though it's occipital. The reason being that it's a combination between all the electrodes in the left. Therefore, we have more information to determine whether, on the left and the right, sorry, to determine whether there was a seizure or not. As it is very helpful because it gives us a global electrocortical activity, as I mentioned before, compressed. In the NICUs, this is for CFM, before NATOs, long time ago, but you can see the screen will show you in 3 hours usually, and then 14 seconds of the EEG. And then it was the brains before NATOs that was, the novelty was there were 2 different channels from left and right hemisphere, and it was very helpful, for instance, in patients with ischemic stroke, in which they will have unilateral seizures, in this case on the right. Then when we analyze the AEG, we need to analyze 3 major areas. One, first of all, if it is a good quality recording. And how is it? The impedance. If it is too high the impedance, we will have a garbage in, garbage out. So we need the impedance to be less than 10 kilo ohms. This is perfect. And this is a normal trace with the baby awake, sleeping, awake. So if we have a high impedance, for instance, will form a waveform that is very abnormal, very unusual, may give us, oh, is this a seizure or not? And so it's a very worrisome if we don't check the impedance. Now, the impedance check is done usually in our traces now in the raw EEG as well. Now, then you look at the background. Now you know, okay, the trace is good quality. Let's look at the background. The background should be the lower margin above 6.5 microvolts. The upper margin should be above 20 to 35 microvolts. And you have awake and, sleep and awake cycling. Very, very nice normal background activity. But then you can see in a very abnormal background activity with burst suppression, more suppression than burst. Here the bursts are starting to rise up, where the upper margin is less than 20 microvolts, and the upper margin and the lower margin is lower than 6.5 microvolts. In this case, it's about 1, if any. So then the background can be classified in a continuous normal voltage, discontinued but normal voltage because of the amplitude, burst suppression, low voltage, and flat trace. And there are 2 classifications, voltage classification and pattern classification, but essentially they're mainly talking about the same thing. There is a normal, intermediate, and very bad one. And And we know that if the bad one remains for more than 36 hours without hypothermia, the positive test probability of a very bad outcome is almost 100%. And if it remains more than 72 hours with hypothermia, the positive post-test probability for having a bad outcome is 95 out of 100. So it's a very reliable tool to predict outcome, even if it in hypothermia scenario. And then the presence or absence of seizures, that's what we look, and it's a very easy to recognize. The seizures, in order to be recognized in the EEG, needs to be prolonged. The longer this eh, time that we use, time frame, 3 hours, 4 hours, 6 hours, these lines will have 15, 20, 30, 60 seconds will be representing. So a very brief seizure, it will be missed. Repetitive seizures are easy to be catch. For instance, you can see the lower margin going up, going up, going up. So repetitive seizure, the sensitivity is about 68%, according to Glass. And here there was a load of medication. While brief seizures, I can ask you, do you see a seizure? Well, this is not a poll, but yes, there is a seizure actually here. And the seizure is right there, right this single one thing line. So brief single seizures are very challenging to be picked up by the amplitude integrated EEG. So another reason why we should think in more broad. So it is really good to predict outcome based on the background activity, not so good for seizures, the amplitude integrated EEG, although repetitive seizures are easy to catch. So let's go back to the rest of the spectral array. You have seizure probability. This is a function in which accounting all the other information that is picked up from the EEG tells us how much probable from 0 to 100 or 0 to 1 that a seizure is occurring. For instance, here it tells us it's very probable that a seizure is occurring, but actually the seizure was very prolonged. This is a 1 hour recording, so it's almost half an hour of ongoing seizures. So it's good, but not the panacea. And then we have, so as I mentioned, you can use it in seizure probability. For instance, if we are not picking up good information or if slow enough, the seizure probability may not capture the seizure. Then the frequency Fourier spectrogram displays, as I mentioned before, the frequencies and time, and it's a color coded, and it can tell us how when the seizure starts. The higher the amplitude and slower the frequency, the more powerful a seizure will be. Therefore, if it is less than 2 Hertz, that may be missed in the amplitude integrated EEG, it may be caught in the fast Fourier FFT. Then we have also the asymmetry index, in which you have absolute and relative. And the relative, one can see that if it goes up, the green is the relative. If it goes upward deflection, it's more likely that there is a more power on the right hemisphere. For instance, in this seizure, as we can see, it's right occipital, the seizure, so it's going up the deflection. And if it goes down deflection, the power is more on the left. And you can see here is going down, and you can see a little bit of left dominance. This was an artifact on the left, but it was picked up because the right hemisphere was flat. And then the asymmetry, it takes the overall activity, the amplitude, frequency, rhythmicity, and see which hemisphere is more dominant. And not only the hemisphere, so it's color coded, left is blue and red is right, but also tells us in the frequency where the best dominant activity happened. For instance, in these very slow seizures on the right, you can see very red dots in this newborn. And then you have the burst suppression ratio that tells us the percentage of suppression. We have a very suppressed EEG. Well, it's not suppressed at all on this patient. And again, color coded. And then peak envelope is an interesting function that I found helpful in newborns. I believe in Persyst is working on this as well, to make it more available for the neonatal care, and in which can pick up seizures as well. And it displayed the medium amplitude of the EEG potentials of consequent EEG epochs and display data over the time axis, as you can see here. In the advantage of this is the ability to exclude transient high amplitude EEG potentials that from the analysis, which often occurs due to motion or electro artifact. The problem with newborns, the electrodes move quite a bit because they are paste based and not glue. And then you have the rhythmicity spectrogram, in which tells you a certain activity is rhythmic or not. Seizures tends to be rhythmic, as you can see in this patient with right hemimegalencephaly, in which you can see frequent seizures occurring many times. This is a 1 hour record, sorry, a 3 hours recording, and you can see how frequent the seizures were. And they were quite rhythmic at about 12 hertz frequency. And if you count this, is this oscillation with a spike, it's around 12 hertz, because it's 6, but it's like but double because of the spike and slow wave. So that's that. And then a new tool we have available is the baseline that also you set up a certain amount of baseline. In newborns, you need at least 30 to 60 minutes in order to capture a full cycle of awake and sleep. And comparing with this baseline that you tell the machine, okay, tell me if anything is different than this half an hour or hour, and the machine tells you, okay, yeah, I can see something different here. I don't know what it is. You have a look, man. It's your problem. But I can tell you that it's exactly there, and it's on the left hemisphere more than the right. And so, poll number 2, Marie, can you show it?
Yes. Poll number 2.
I hope I'm not talking too quick.
It's wonderful. Okay.
All right. Yeah, we can see it. So let's see. What do you see? So now you have gone over all the details about how to read a background in different frequencies, in different trends. So I'm including the Amplitude Integrated EEG, also seizures, and so I'm wondering if you're able to tell us what you see now.
Okay, we have
this is a 6 hours recording. Keep that in mind.
Good point. We have about 40 responses. Let's let a little bit more time so that people can get their answers in.
Yeah, they need to read a little bit more here. And also be reassured these are just anonymous, so nobody cares if you successfully fail.
So, just for you. That's right.
Yeah.
Self-assessment. Okay,
all right.
so we have close to it. Yeah. All right.
Yeah.
Poll ending in 3, 2, 1. And here are the results.
All right, good. So yes, we are seeing an abnormal background activity. They were more answers stating that there were seizures, which is very reassuring that they were paying attention. However, they weren't seizures, they were kind of tiny artifacts. Um, it was mainly uh, ongoing, continuous over 6 hours, evolving from a very severely sick child to an unfortunate outcome of brain death and passing away over 6 hours. So you can see how devastating the um, um, the Streptococcus beta hemolytic group B can be. So it's a very sad, but it can tell you the behavior of the brain throughout several hours and how it evolves. All right, so we can close the poll. That's a note. I'm going to try to continue with another case. Marie, stay with us. Soon will be the poll number 3. So this is a case 2 in which there was an emergency C-section due to acute decreased movements and lack of heart rate detected and prenatal monitoring. Very abrupt. Let's get out of here. It was difficult, the extraction, because the child was already in the birth canal and it was being pushed down. So they have to take it up from the birth canal through the C-section. So now, poll number 3, what do you see? Similar question as before. The order, we tried to put the order same as before, so you guys have A, B, C, D, and E, all the same. And
the duration is 2 hours, I'm noticing.
Perfect, thank you very much. Good point, Marie. And we are seeing these traces, and I can tell you this is a very nice way of looking at several EEG waveforms at the same time as well. You can see um, um, in the also by quadrants and midline, and as well as the FFT spectrogram, the rhythmicity, and the asymmetry, in which newborns, most of them have focal seizures, and I found sometimes helpful to have it. So I'm just talking so that you cannot think and you answer whatever. Do we have enough respondents?
We have close to 100, yes. So
okay.
The poll here will be ending in 3, 2, 1. And there are the results.
Great. So we have people that says normal background and people that says abnormal background. And I think the abnormal backgrounds without seizures won because it's 36%. So we're gonna briefly discuss a little bit about this, but this background activity for a newborn is quite suppressed. You can see here in the Amplitude Integrated EEG, it's a very suppressed and maybe even discontinuous background activity. It's not the nicely formed awake and sleep. However, these look like awake and sleep, and that's why probably people answer more normal. But guess what? These were, if I, okay, I'm gonna, can we close the poll? So I think if I would have shown you these, you probably would have guessed a little bit better. That is a more suppressed background with possible seizures coming from the midline. And you can see this arrangement is a very interesting one because it tends not to miss anything from FP1 to O1. So the whole anterior to posterior is comparing. And then you compare the right as well from anterior to posterior. And then the midline, which is the typical traditional C3 to C4 that was back then used by CFM the Olympus and now the Natus. So these tiny oscillation that we thought could have looked more as a sleep and awake cycling, they were actually focal seizures over the right central head region. And that's why it was very well picked by the midline electrode and not so much by the other electrodes. Although you can see in the right much more oscillations than on the left, and you need to compare apples with apples. So if you go with the FP2 compared to C4, you go with FP1 compared with C3, because those are homotopic contralateral areas. And you can see how asymmetric and different functions you have in those two. Another way of arranging it would be putting the pairs left and right, left and right, left and right. That's another way of looking at this as well. So in order to see the other ones, you could see now that you have learned that pattern and you can recognize the tiny dots on the right anterior central. You see all these dots are seizures. Those are the seizures that we were not seeing. You compare with the left anterior, it's fairly asymmetric. And then if you look clearly on the right anterior, you can see there is a little bit of increase in those areas of frequency, particularly here at the 1 hertz or so. It's a very, very subtle, so I'm not gonna tell you if you don't see it, that's okay. But you can sometimes appreciate a little bit of dominance on the right hemisphere in the lower frequencies because the red is a little more bright. Okay, so yeah, I was just showing you all the modalities so you believe me, these are seizures. But now be aware. Be aware, as we mentioned before, the baseline, which is a very helpful tool whenever you have a good baseline to compare with. But if we use a baseline in which we have seizures, as you can see, there are seizure, 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 seizure. So it's not going to recognize nothing. It's a very difficult area to, and so the pattern is missed. So there are certain waveforms or certain trends that we can use, meanwhile we have the good baseline to compare with. So it's something that I discovered over the weekend trying to play around with the baseline software. Maybe that is not well properly set up. Our colleagues in Persyst may be pulling the hairs. What are you talking, JP? But I think it's that, and you can see why he had right central seizures, because the child had to be extracted with forceps, and unfortunately there was a fracture and a brain injury because of that. But the child would have died otherwise. So diverse trends or different arrangement of the same trends can help to differentiate different seizure types that are unique to each patient. So keep that in mind. But be aware that not all the trends can be used in all scenarios. So why don't we use them more often then if they are so helpful? Well, the problem is that in order to have such a beautiful information, you need to use a lot of electrodes. Because if you use only 2 electrodes, the brain waves that you're going to be generating are very poor. The trends are very poor. There's not enough information to have a good conclusion. Therefore, we need to use at least the 11 electrodes as a neonate. And how do we do that? Well, there are certain tools. I'm just showing this because it's the one we use here, but there are many nets that can help the NICU team to set up the electrodes in the appropriate position, or kind of where they should be in order to capture enough. And this was the brains before the Olympic, and this is the regular setup for our EEGs. Now, why is it important to have the more electrodes, the better? well, here are a nice example with a left frontal focal seizure, very focal. Newborns tend to have very focal seizures. Um, so C3, C4, sorry, C3, P3, like a brain's arrangement, 2 channels, did not pick up seizure, full neonatal, 11 electrodes. One could argue, maybe I see something in the left uh, anterior frontal. However, if you put the full montage, the 19 electrodes, you can clearly see the seizure in the left frontal head region. In a newborn, when it's a very focal seizure, if you don't use whole montage, you may miss it. So for instance, the seizure was here. So in our institution, our colleagues in the neurocritical care, Dr. Eser and Dr. Mohammad, are very interested in developing this neurocritical care monitoring, and it's a very unique program we have here. When Jeff Buckhalter was also around, and Dr. Bello Espinosa, we we looked at the application of these. We taught the nurses how to put the electrodes with the nets and when to start it, even after hours. So our techs would cover up to 6, 8 p.m. And then overnight will be the nurses hooking it up, turning on the machine, putting it on, and making it available for the physicians on call at night to look it from home. We look at 192 of these continuous video EEG, and there was a decrease in almost more than 1 day of in the delay to initiate the monitoring. So even weekends, we were able to put them on and look at them. When weekend, it's a little more short the time cover by our techs. So it's a very helpful tool, reduces the time of onset, increases the electrographic seizure detection, decrease the seizure clinical misdiagnosis, because we overdiagnose with many movements of these babies do. And with that, we reduce the use of anti-seizure medication burden, which in turn was more hemodynamically stable, that patient, therefore shorten the hospital stay and improve the care overall in the infants. And even more, we were able to recognize patients that needed to go to hypothermia and put the EEG on. And with that, there was a decrease in brain MRI injury, which they measure in the serial MRI. We have a protocol here that we do the MRI at day 5 of life, sorry, 3 to 5 of life, and we can look at the brain injury. So in collaboration with our NICU team, we could improve the utilization of new trends leading to patient care enhancement. And that's something very important that we all need to consider here, collaborating with our teams and in order to improve our baby's care. Now, one last topic before we end. Can trends suggest a particular etiology? Well, let's see. Poll number 4 and last.
Okay, here we go. Poll number 4.
Again, can you recognize a seizure? We are almost done. Hang on tight. We'll be there in 5 more minutes.
Okay, we have a lot of responses coming in.
Okay, good.
Yeah, this is great. We'll give it just a few more moments. I really like this interactive part.
Hopefully, I can see in real time where we need to emphasize the ideas.
There you go.
Right?
Yeah, exactly.
Okay, I think we can move on. How
okay.
many?
All right. Poll ending in 3, 2, 1. And here are the results.
Yes. Great. That's correct. Exactly where you pointed. So here we can see a very nice increase of the lower margin going up, the upper margin a little bit as well. You can see a clear rhythmicity picked up by our rhythmicity spectrogram, as well as an increase in power picked up by the FFT. Now, one could say, all right, well, the asymmetry is not that helpful, JP. Well, why don't we see either left or right? What happened here? Well, what happened actually, is that this is a very unique seizure type. It's a seizure that, as you can see, the very onset is a diffuse attenuation. The whole brain becomes engaged in the seizure almost from the very beginning, even though there is no generalized seizure per se in the neonatal seizure classification. They have addressed this as a sequential seizure type. Um, and you can see it in all the amplitude integrated EEG trends, in all the brain coming along at the same time almost. And this has recently been described by Villa et al. As associated with KCNQ2 mutation, in which you have abrupt a downward deflection of the upper limit and lower, sorry, upper margin and lower margin, and then a straight going up almost of the lower margin and upper margin, and then gradually coming down as a post-ictal at suppression, and then gradually picking up again the, the, the normal brain activity. This is a 6 hours, 6 centimeter per hour. This is the regular screen that you see in the NICU. So these seizures are very difficult to pick up if you're not really paying attention. But the good thing is they're very clinically obvious at the beginning before medication, in which the patient have diffuse tonic posturing. And here we have a patient that recently was admitted in our unit that we don't know just yet whether has KCNQ2, but we were able to adjust our management accordingly. We came up with in a poster we presented in AES that we picked up several cases that were not only KCNQ2 but also KCNQ3 and SCN2A. We came out with a checkmark seizure idea. But really, as you can see, if you spread a little bit, this is kind of 1 hour recording, you can see, so it's 20 minutes, this. So you can see there is a little bit of a check mark that you can see, and it's usually diffuse, the whole brain, but it can be unilateral, hemispheric. And why is that? Because there is the seizure starts around here, diffuse attenuation, which that leads to the decrease of the lower margin, and then gradually build up of the amplitude with tonic-clonic, which leads the upward deflection of the AEG, and this one you can see in real time. And then gradually, you don't see here, but there is a diffuse attenuation post-ictally, so which is a suppression. So we have desynchronization, attenuation, a tonic-clonic or rhythmic activity, and followed by diffuse attenuation post-ictal suppression. And this is the poster we presented. We have 9 cases, and interestingly, when we were presenting this, one of our colleagues picked up another patient, knowing now the pattern, having learned about this, and it was an SCN2A. So in our case, we don't know if it is the one that we just got last week, whether it's ACNQ2A, KCNQ2 or 3, but the answer is yes. There are certain patterns that could suggest a channelopathy at least, and can help guide the precision medicine. In our case series, 89% of the patients responded to sodium channel blockers, either fosphenytoin or oxcarbazepine, which is, again, a very helpful information to have in mind. If we see this pattern, we can target with the precise treatment for these patients. So the more we use them, the more we discover how valuable they are. So I think we are done with the presentation. Here are the conclusions. Essentially, this is a summary of all the things that we have discussed already, the concepts. So it's just for you to have it all together in a single slide. So thank you very much for your kind attention, and I will be more than happy to answer any questions if there are. Thank you very much.
Wonderful. Thank you very much, Dr. Appendino. That was a wonderful talk, very educational. We had a couple questions come in, mostly about whether or not the recording would be made available. So those are easy ones for me to get. And we do have one question. It says, to get trends minimum, how many minutes recording should be done? And if I'm interpreting this, I am wondering if it's a question about baseline. How long do you have to record to get the trends in order to understand what's going on? But I won't go further than that. I'll let you answer.
Yeah, thank you. Yeah, that's a very good question. Usually, in order to have a good trends, we need at least several hours to understand the overall brain function. But in newborns, at least 1 hour of recording in order to see the healthiness of this brain activity, the awake and sleep cycling is very helpful. But we tend to have at least 4 to 6 hours of recording in order to have a good understanding of the trends. In our institution, we have a protocol. We monitor for 24 hours. If the baby comes with query seizures or episodic events, we monitor for 24 hours. If no seizures, then we disconnect. If we are at 20 hours before the tech goes home and the brain activity has been normal so far, then the chances are low to have seizures as well. So we tend to disconnect, but usually we need at least several hours. It's a very good question that I don't have the precise answer for you.
Again, thank you very much for a wonderful talk. And if anyone has any questions, you can reach out directly to support@persyst.com. And you can also visit the Persyst Grand Rounds website for the schedule. And I want to thank you again very much to Dr. Appendino for his time today. It was really a wonderful talk. Thank you very much.
Well, thank you actually. And I hope you have a wonderful day and a lovely week.
Thank you.
Right.
You as well.
Bye,
Bye, everybody.
Thank you. Bye, everybody.